Hello, everybody. Thanks very much for joining us tonight for Lipoprotein A today and tomorrow with our featured speaker, Dr. Calvin Yeang. I'm Dr. Mary McGowan, the Chief Medical Officer of the Family Heart Foundation. Next slide. So we always have a medical advice disclaimer. The information in this webinar is for your information. The content, though, is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not constitute medical or other professional advice. Medical information does change constantly, and information in this webinar could be updated or changed. So I would follow up with your doctor or your healthcare professional, medical team for specific recommendations pertaining to the treatment of you and your family. Next slide, please. I'd like to welcome everybody and ask you to use the chat to introduce yourself and tell us where you're from. Make sure to change your chat settings to everyone from host and panelists. Change it to everyone so that we can all meet you. And then as we go forward, you're going to be sending your questions through the Q&A, not through the chat. Next slide. Again, if you have a question, we'll be collecting them throughout the entire lecture. And so if you have a question for our speaker, you can put it in the Q&A, and then we'll give you the answer either at the end. We'll try to get to as many as possible, or we may even answer some on the during the session. Next slide. I want to thank our sponsors. We could not do this without them. And so we gratefully acknowledge those sponsors that are listed here. And now I want to take the opportunity to introduce you to Dr. Calvin Yeang. Dr. Yeang is at the Cardiovascular Institute at the University of California, San Diego. Dr. Yeang is an MD and PhD. He's a board-certified cardiologist who specializes in general cardiology and heart disease management, as well as preventive cardiology, echocardiography, and lipid disorders, including lipoprotein A. In addition to teaching medical students, residents, and fellows at UC San Diego School of Medicine, Dr. Yeang is a physician scientist with an active translational research laboratory with the aim of improving prevention and treatment of atherosclerosis and aortic valve stenosis. Specifically, Dr. Yeang's research focuses on understanding non-traditional but common risk factors such as lipoprotein A. This research has been funded by the American Heart Association, by the National Institutes of Health. He's co-authored many peer-reviewed articles, and his work has appeared in many journals: Nature, the Journal of the American College of Cardiology, Circulation, European Heart Journal, and JAMA Cardiology, among others. So Dr. Yeang, we're very pleased to have you to speak to us, and we're really interested in hearing what you have to say.
Thank you so much for that kind introduction, Dr. McGowan, and I'm really happy to be here in spirit of the Lp(a) Awareness Day. And what I'd like to talk to you about is kind of the basics of Lp(a), and the title of this talk is going to be Lipoprotein A, a causal common cardiovascular risk factor. Here are my disclosures. And in the spirit of Lp(a) Awareness Day, I'm going to be discussing lipoprotein A, or Lp(a) for short, and focusing on the basics of lipoprotein A to promote an understanding of why one should be aware of Lp(a). It's my hope that following this talk, you'll understand what Lp(a) is, how Lp(a) influences cardiovascular disease or heart disease risk, and how heart disease risk can be modified in patients with elevated Lp(a). There's strong supporting evidence for the role of Lp(a) as a causal risk factor for all facets of atherosclerotic disease, or disease related to plaques in arteries, including heart attacks, ischemic stroke, peripheral arterial disease, as well as calcific aortic valve disease, or stiffening of the aortic valve, called aortic stenosis. Importantly, high Lp(a) levels are also associated with an increased risk for mortality due to heart disease. Elevated LPA levels are very common in the general population, and 20% of North Americans are estimated to have levels of 50 milligrams per deciliter or 125 nanomoles or higher. And these are the levels considered to be significant for heart disease. This means that 1 in 5 people may have elevated Lp(a). Now, one caveat here is that there are ethnic differences in the distribution of Lpa levels in the population, with the highest levels seen in Blacks, then South Asians, then whites, and lastly Hispanics and East Asians. In East Asian populations, for example, where Lpa levels are lower, only 10% would have levels greater than 50 milligrams per deciliter. So depending on your racial backgrounds, the distribution of Lpa might be different. But a main point here is Lpa levels are generally common across all populations, and relative to how infrequently Lpa is assessed clinically, it represents a very vastly underappreciated risk factor. Next, I'd like to review the biology and the genetics of Lpa, which I think are very important to interpreting the evidence connecting Lp(a) to heart disease risk. So Lp(a) is a lipoprotein, meaning that it consists of lipids such as fats, including cholesterol, phospholipids, and triglycerides, as well as proteins. It shares similarity with another lipoprotein you might be all familiar with, LDL, or bad cholesterol. However, what makes Lpa unique and more toxic than LDL is the presence of a protein called ApoA that's covalently bound to the LDL particle. ApoA also binds pro-inflammatory and pro-calcific oxidized phospholipids. And in addition to the oxidized phospholipids that's present on ApoA, Lpa contains oxidized phospholipids in the lipid phase, so in the admixture of all the other lipids. And Lp(a) is the predominant lipoprotein carrier of oxidized phospholipids. It's also interesting to note that ApoA, again, this is the protein that makes Lpa unique, evolved from its neighboring plasminogen gene, specifically through duplication of plasminogens Kringl's 4 and 5 and protease domains. And throughout its evolutionary course, the Kringle 4 domain of ApoA expanded into 10 subtypes. And there's genetic polymorphism in how many copies of Kringle 4 type 2 an individual has. Depending on the inherited allele encoding ApoA, individuals can have isoforms containing 2 to more than 40 Kringle 4 type 2 repeats. And this point is important because the ApoA isoform size is a major determinant of the heritable high levels of Lp(a). And Lpa levels are largely determined by the rate that the liver synthesizes, makes, and secretes the Lpa and ApoA, such that larger ApoA isoforms are associated with lower Lpa levels. And these isoforms, and this association exists because these large isoforms are less efficiently produced and secreted by the liver. In addition to ApoA isoform size, there are other genetic determinants of Lpa levels, including single nucleotide polymorphisms, or SNPs for short, in and around the Lpa gene. There are also sequence variations within the Kringle 4-2 repeats that are not fully understood yet that can possibly influence Lpa levels. Other genes, non-related and not related directly to Lpa, such as ApoE, CETP, and ApoE, also influence Lpa levels. There are also non-genetic factors that can influence a person's Lpa levels. And examples of this include Lpa levels rising following menopause, when estrogen levels fall off, or Lpa levels rising in patients with poorly controlled hypothyroidism, suggesting that Lpa is under control of thyroid hormone, amongst other hormones. Lpa levels also increase during advanced kidney disease, suggesting a role in the kidneys and metabolism and catabolism of Lp(a). However, even in light of those non-genetic determinants of Lpa levels, Lpa levels are largely genetically determined. Between ApoA isoform size, SNPs in the Lpa gene, and the other determinants that we discussed in the prior slide, Lpa levels are 90% determined by genes. This means that if high levels are inherited, it's likely that the individual will continue to have high levels throughout their lifetime. LPA levels are inherited in an autosomal codominant manner. This means that first-degree family members of individuals with high LPA will each have a 50% chance of inheriting high LPA. So therefore, elevated LPA levels are common, but even more so in families that have high LPA. Our understanding of LPA as a risk factor for heart disease comes from investigations understanding the biology of LPA, as well as observations in persons with elevated LPA. There are many biological aspects of LPA that promotes the risk for heart disease. LPA, as we had discussed earlier, is the predominant lipoprotein carrier of oxidized phospholipids, which are pro-inflammatory and procalcific. Additionally, the particle is atherogenic or promotes plaque-forming processes due to the ability of ApoA to bind fibrin that may be exposed at sites of endothelial injury or valvular injury. LPA also promotes smooth muscle cell proliferation, which is a key process in the progression of plaque. There's also a possible role for LPA in thrombosis or clotting that may be separate from its role in promoting plaques in arteries, but this is an area that's not quite fully understood yet. Next, I'd like to discuss investigations involving persons with high LPA and why LPA is considered a likely causal risk factor. Now, key to this is a population genetic study design called Mendelian randomization, which was designed to overcome the limitations of traditional observational studies that cannot distinguish between causality, reverse causality, and confounders. Using LPA as an example, and all that was known about LPA was that there was an association between LPA and cardiovascular disease risk through traditional population-based studies. We would not be able to distinguish whether LPA causes cardiovascular disease, which is depicted by the blue arrow, or if they were instead reverse causality indicated by the red arrow. For example, one can imagine the possibility that having cardiovascular disease in turn raises LPA levels. However, because LPA levels are strongly genetically determined and levels are stable throughout one's lifetime, a Mendelian randomization approach can be used to test causality. And a Mendelian randomization studies are named after randomized clinical trials due to the parallels they share. Individuals in a Mendelian randomization design are grouped together by their genotype, which is assigned at birth and distributed randomly in the population. In this type of analysis, genetic determinants of LPA can be associated with risk, and this is depicted in the schematic here by arrow number 3. And because one's genes are not altered by cardiovascular disease nor other confounders, this association can be considered causal. And then, because LPA levels are highly genetically determined and causally associated with ApoA isoform size, for example, or LPA SNPs, this three-way association between high LPA levels, genotype encoding such levels, and cardiovascular disease risks can suggest a causal relationship between LPA and heart disease risk. In addition to Mendelian randomization studies, there is now a large body of evidence that further support a likely causal role for LPA and various aspects of heart disease and aortic valve disease. Most notably, there are high-quality observational studies or meta-analyses and GWAS studies associating elevated levels of LPA with myocardial infarction, heart attacks, coronary artery disease, and calcific aortic valve disease or valve stiffening. There are many excellent review articles that summarize all of these findings, and for your reference, I listed 2 such examples, one of them being the AHA scientific statement on LPA, and another the National Lipid Association guidelines on LPA. In addition to heart attacks and aortic valve disease, there are also high quality and large observational studies and meta-analyses and Mendelian randomization studies that link elevated LPA levels with ischemic stroke, peripheral arterial disease, and cardiovascular mortality. Now that we reviewed how common LPA is and that it's a likely causal risk factor for heart disease, let's discuss who should have LPA testing. The major societal guidelines internationally have provided recommendations on when LPA testing may be appropriate. And here we'll review the key takeaways, which I bolded. The European Cardiology Society and the Canadian guidelines recommend checking LPA at least once in each person's lifetime to identify individuals with high levels. This strategy works because LPA levels, again, are highly genetically determined and largely stable over time, so that one single measurement may be all that's required to screen for those with high levels. The American Academy of Clinical Endocrinologists, AACE, guidelines recommend considering LPA testing in all patients with clinical cardiovascular disease. Most guidelines, including American guidelines from the AHA and the ACC, as well as the NLA, provide at least a relative indication to measure LPA in those with a family history of premature heart disease or personal history that's not explained by major risk factors. Let's now review how we assess heart disease risk in patients with high Lp(a). So this figure, which is taken from a large population-based study called the UK Biobank study, consisting of almost 500,000 patients or individuals, shows that there is a linear relationship between higher levels of LPA and risk for heart disease. This data tells us that LPA levels, or the risk associated with LPA levels, is proportional to its blood levels. And the increase in baseline risk can range from to be marginal up to over twofold, depending on how high the LPA levels are. And overall, there's an 11% increase in risk for every 50 nanomoles, nanomole, higher levels of Lp(a). Now, while population-based studies are very incredibly important and informative about the risk attributed to Lp(a, independent of other risk factors, which was the analyses I've shown in the previous slide, the other risk factors are quite relevant to the individual, the patient, or the person with high Lp(a). And these other risk factors, such as gender, age, race, cholesterol levels, diabetes status, blood pressure, should all be considered in context with Lp(a) in order to really have a comprehensive risk assessment. Now, clinicians routinely use risk calculators that estimate a patient's 10-year risk for developing heart disease based on these traditional risk factors. And most calculators do not consider Lp(a) in their estimates. And we have described a strategy to personalize the risk assessment associated with Lp(a), incorporating Lp(a) levels with these traditional risk factors. And we had described this in the AHA scientific statement that was published earlier this year. And what we, the information on the slide was directly taken from the guideline, from the scientific statement. And what we have recommended was one can use an existing clinical risk prediction tool that accounts for the traditional risk factors. And LPA attributable risk can be then incorporated into that 10-year, for example, estimated risk using the hazard ratio adjusted for traditional risk factors in the UK Biobank study of 1.11 for a 50 nanomole increment of Lp(a). So as an example here, if a patient has a 10-year estimated risk of 10% based on traditional risk factors, and the patient's Lp(a) is elevated at 250 nanomoles, his or her true 10-year risk would be closer to 17%. Patients with familial hypercholesterolemia, or FH, are a high-risk population, in contrast to the UK Biobank population I described, which is sort of the general population. But even in patients with FH, as represented in the safeguard cohort, with data shown on the left-hand side of the screen here, were those with severe hypercholesterolemia in the FH range, represented by the Copenhagen General Population Study shown on the right. Elevated LPA levels in these populations still identify people who are high risk. And those with both a diagnosis of FH and elevated Lp(a) are in the highest risk category. In addition to modeling for LPA risk or LPA associated risk based on the levels of LPOA and traditional risk factors and whether the patient has FH or not, there are also other risk modifiers to consider. Now, we know that not everyone with high LPOA is destined to develop cardiovascular disease or heart disease in their lifetime. One very useful biomarker to refine risk in patients with elevated LPOA is a high sensitivity CRP, or C-reactive peptide. CRP is a biomarker of systemic low-grade inflammation, which makes sense concerning how LPOA largely mediates disease through pro-inflammatory pathways. And this data that I'm showing on the slide is from the MESA cohort, which is a population of 4,500 individuals without clinically evident disease at baseline. And cardiovascular disease risk attributed to higher levels of LPOA was significantly attenuated when the hsCRP levels was normal or below the typical cutoff of 2. Another very useful clinical tool to refine or personalize heart disease risk in patients with elevated LPOA is a CT coronary artery calcium score. This clinically available imaging modality quantifies the amount of calcification in the heart arteries and is a marker of the burden of atherosclerotic disease that's present in any given individual. In patients with elevated LPA, but without coronary artery calcium, or coronary artery calcium score of 0, in other words, the risk for cardiovascular disease events, such as heart attacks, is low. However, in those with high LPA and elevated coronary artery calcium, the risk is high. This makes sense as the imaging test identifies those who have developed disease in the presence of risk factors, and those who, despite having risk factors, may have protective factors and have not yet developed significant atherosclerotic disease. So by incorporating a patient's traditional risk factors, their LPA levels, and additional biomarkers such as ACRB and coronary artery calcium score, we can estimate risk in patients with high LPA, and based on the risk, determine a plan to reduce that risk. Now, when the issue of how to modify risk in patients with high LPA comes up, I'm often asked which therapies lower LPA. So this is a systematic review where we describe the effects of common lipid-lowering therapies and diets on LPOA. The main points I want to make here are that statins, which are commonly used to prevent heart disease, can actually raise LPA modestly by 11%. And more on this later. Diets that are often prescribed to patients with high cholesterol, such as low-fat diets and elevated risk, they don't lower LPA and can be associated with also modest elevations. Therapies such as niacin, PCSK9 inhibitors, and lipoprotein apheresis do lower LPA. And there are investigational therapies such as RNA therapeutics against LPA, and those can be very effective at lowering LPA. However, it's important to note and understand that we cannot yet conclude whether LPA lowering specifically improves outcomes until randomized clinical trials with agents that specifically lower LPA read out. And this data will soon, hopefully, should be available in the next couple of years. There are ongoing trials testing RNA-based therapies targeted at the LPA gene that lower LPA by 80% or more at optimal doses. And here I'm showing two such examples. With the antisense oligonucleotide, or ASO, pelacarsen being more advanced in clinical trials and now in phase 3 trials. There is another compound, an siRNA compound, that is very promising now in phase 2 trials. And there are other additional RNA therapeutics that are many other emerging therapeutics that are even earlier in the trials, but we hope that together these will provide lots of potential options in the future. But while we eagerly await readout from these trials, there are existing therapies that may reduce the risk associated with LPOA. And therefore, in the meantime, until we get data from these randomized trials, we should shift our focus from what interventions may lower LPA to what interventions may reduce the risk in patients with high LPA. We know that healthy habits are associated with lower risk in general, but this also applies to patients with high LPA. And this is data from a population-based study of over 14,000 individuals in the EPIC Norfolk study. And even in a group of patients with elevated LPA, here defined as LPA over 50 milligram per deciliter, or roughly greater than 125 nanomoles, an ideal control of lifestyle factors, including body weight, healthy diet, regular exercise, non-smoking status, normal blood pressure, non-diabetes, is associated with relatively low risk. So even if a healthy lifestyle and diet are not likely to lower LPA levels, again, are genetically determined, it's still likely to be helpful in reducing overall risk in patients with high LPA. There's also evidence that certain existing therapies, pharmacologic or otherwise, can modify risk associated with high LPA. And we'll review a few examples in the context they were studied. So first is the secondary analysis of the Jupiter trial, which is a primary prevention trial, testing whether statins can lower the risk in those who have not yet developed clinically evidence of heart disease. And in this trial, which enrolled patients with an LDL cholesterol, bad cholesterol less than 30 milligrams per deciliter, and an elevated HSCRP greater than 2, it showed that the overall trial, meaning that these trial participants randomized to get rosuvastatin, did have a reduction in cardiovascular endpoints. But in the secondary analysis, where the population was stratified by those with elevated LPA or those not, even in the population that had LPA above the median or higher LPA levels above the median of 23 nanomoles in this population, there was benefit in terms of a risk reduction. So even though statins do not lower and may raise LPA levels by 9 to 20%, it suggests that statins, either through LDL lowering or other potentially pleiotropic effects, can reduce risk in patients with high LPA. Now, the caveat here is that in this trial, most patients had low LPA levels, as evidenced by the relatively low median LPA levels in this trial, 23 nanomoles or 10 milligram per deciliter. So we don't quite fully know whether in patients with very high LPA levels, how effective statins might be. And the other caveat to point out here is that there is residual risk compared to patients who have low LPA. Patients who have elevated LPA in this trial had their risk reduced, but to a lesser extent than those with low LPA. Secondary analyses of the large outcome trials with PCSK9 inhibitors, specifically evolocumab and alirocumab, which were given on top of statin therapies in all the trials, can also reduce risk associated with high LPA. And this was studied in patients with clinically evident heart disease. Unlike statins, PCSK9 inhibitors can lower the LPA modestly, somewhere between 15 and 30%. But they also lower the LDL cholesterol very potently, 50 to 60%. And in the secondary analysis of the PCSK9 inhibitor trials, patients with LPA levels that were elevated, meaning greater than 50 to 60 milligrams per deciliter, and treated with PCSK9 inhibitors, had actually a 25% risk reduction in cardiovascular outcomes in both trials. Moreover, it appeared that those with higher baseline LPA levels had higher risk reduction on PCSK9 inhibitors. Lastly, observational studies have shown that LPA and LDL cholesterol reduction with lipoprotein apheresis was associated with a reduction in cardiovascular endpoints after the initiation of lipoprotein apheresis treatment. This was compared to event rates before starting treatment. Importantly, the FDA has approved lipoprotein apheresis for patients with LPA levels greater than 60, LDL greater than 100, and with clinically evident disease, such as coronary disease or peripheral artery disease. So with that, I like to end with a couple of takeaway points. And, I like to, I think it's going to be important for patients or people in general to discuss with their physician and their healthcare provider about checking LPA levels, which is a simple blood test, especially if the patient or person has heart disease or a family history of heart disease. And if your LPA level is high, your risk for heart disease can be estimated in the context of the other risk factors, additional biomarkers, and imaging. A healthy lifestyle may reduce risk associated with high LPA. And if one's overall risk for heart disease is high with high LPA, additional therapies may be implemented to reduce risk. And lastly, we end with some hope that more specific therapies and potent therapies addressing LPA-mediated risk will be available soon should the clinical trials that are ongoing show that these therapies are safe and effective.
Great. Thank you so much for that very insightful talk, Dr. Yeang. And we have gotten a few questions that have come in through the Q&A. And there are several people who are interested in the issue of how thyroid hormones may influence lipoprotein (a). And there was one question about would there be a consideration of giving even euthyroid people small doses of, say, levothyroxine? Any thoughts?
Yeah, good question. We think that there's probably genetic regulation of ApoA based on all different kinds of hormones. For example, there are likely elements that regulate ApoA expression that respond to hormones, whether it's estrogen, thyroid hormone, etc. This becomes very relevant in patients who are hypothyroid and poorly controlled. I don't think we have the data to know if giving people who don't have, who have well-controlled thyroid levels or not hypothyroid, whether that may help reduce LPA levels. My sense is it probably wouldn't do very much. And, again, I would try to think about LPA in terms of modifying the risk associated with LPA by looking at therapies that have, or therapies or interventions that have been associated with risk reduction, and probably not focus so much on the LPA levels at this point in time. We do hope that eventually, if we do get positive trial results from specific LPA lowering agents, then I think we might be able to know which levels to target for LPA and which levels that we can bring this down.
Absolutely. Another question came up that wondering whether or not the antisense oligonucleotides or the small interfering RNA, do they have any role in reducing not just Lp(a), but do they also reduce the oxidized phospholipids associated with Lp(a)?
Yes, yeah. So that's that's been looked at least in the pelacarsen trial. So the pelacarsen antisense oligonucleotide is effective at lowering the Lp(a), and at optimal doses it lowers the Lp(a) by 80%. And it lowers the oxidized phospholipids 80% as well. So it seems to lower it in proportion to the LPA lowering, which makes a lot of sense as LPA is really the major carrier, lipoprotein carrier of oxidized phospholipids.
Great. And another question that came out was, at what age would you recommend checking Lp(a)? If you ascribe to the once in a lifetime, what would be the ideal age?
Yeah, good question. And so those guidelines, the European guidelines and the Canadian guidelines specifically refer to adults. So they would recommend that we check once in a lifetime in those who are over the age of 18.
And another question that came up was, a person noticed that you called Lp(a) a likely causal cardiovascular risk factor. Hasn't it been proven, they ask?
Yeah, certainly the body of evidence supporting Lp(a) as a risk factor is very profound. And, it's supported in all types of population-based studies, as we described, genetic studies, observational studies, etc. But I think, it depends on what one's definition is for causal risk factor. I think the strict definition would still require that we have a trial, for example, a clinical trial where we test a specific and potent agent that lowers Lp(a) and have that shown positive effects on outcomes. So, I think short of that, I personally refer to it as a likely causal risk factor, but I think the takeaway message is that there is quite a profound body of literature supporting the role of Lp(a) as a likely causal risk factor for heart disease.
And somebody else asks, since statins raise lipoprotein little a, why not just use a PCSK9 inhibitor and niacin to help lower a person with high LDL as well as high LP little a's LDL level instead of using a statin?
Yeah, that's an interesting question. It's almost a compound question. So
it is a
I think one aspect of the question is does a regimen including niacin, would that be helpful? That remains to be answered. Niacin is effective at lowering Lp(a), and there is a heterogeneous response in how much one might expect niacin to reduce Lp(a). But on the other hand, niacin in all its randomized clinical trials hasn't been shown to yield cardiovascular benefit. So, I think there's a paucity, there's a lack of data here. We don't have a clinical trial which is dedicated in treating patients with niacin, dedicated in randomizing patients with high Lp(a) to niacin, with or without niacin, and looking at cardiovascular endpoints. So we don't, at this point, know if niacin is effective at modifying the risk of patients with high Lp(a). But in general, niacin has not been effective at modifying risk despite lowering LDL and raising HDL. I think if we go strictly by the evidence that's out there, PCSK9 inhibitors in combination with statins, that's what we have data available for. And I mentioned this in combination with statins because the PCSK9 outcomes trials treated patients who were predominantly statin treated. So 70 to 80% of patients in those trials were on statins and then were randomized to a PCSK9 inhibitor or not.
Another person says, I understand that baseline levels and risk given an LP(a) level vary by ethnicity. So certainly we know that, and you mentioned yourself that certain ethnicities or races have higher LP(a). But I think the question is if you have high LP(a), is it the LP(a) level that predicts risk, or is it the fact that a individual of a certain race has an elevated level?
Yeah, so when this data is really well answered in the UK Biobank. There are other population-based studies, the Dallas Park study, for example, that looked at this, and there does seem to be differences in risk thresholds. So, for example, Blacks have higher levels of Lp(a) in general, and the distribution of Lp(a) in Blacks is different than in Caucasian populations, where it's almost a normal distribution of Lp(a) levels instead of this very skewed distribution that we see in Caucasians, such that about half of Blacks may have Lp(a) levels higher than 30 milligrams per deciliter, but obviously not half of Blacks have heart disease. Not half of Blacks have heart disease due to Lp(a). So, the distribution of Lp(a) might be different between different ethnicities, but the relationship, this linear relationship of higher Lp(a) levels and increase in risk seems to be consistent across different ethnicities. And this was looked at in the UK Biobank study, where regardless of the ethnicity, for every 50 nanomolar increase, there's roughly a 1.0 to 1.11 increase in risk per 50 nanomolar increase. So the way that one approach to incorporate understanding how race and Lp(a) levels interact would be to use a risk estimator. For example, the pool cohort equation, which we can get from the AHA-ACC website, that does incorporate risk into the 10-year predicted risk, and add on the Lp(a) value, add on the Lp(a) information to that risk calculator. And you can do that with the suggestions that we had put in the AHA scientific statement on Lp(a).
That's great. Another question, it refers to David Ludwig, who is an obesity specialist, said just published a study in January in the American Journal of Clinical Nutrition demonstrating that low carb diets lower LP(a) by 14.7%. Your thoughts?
Yeah, there are. I have to admit, I'm not an expert on diets in general, but I wouldn't be surprised if there are differences in LPA levels with diets and differences in LPA levels with weight loss. For example, there is a study that with extreme weight loss after bariatric surgery, LPA levels can go up actually, which is quite interesting. But again, my approach, my personal approach is to think about, what can modify risk with LPA and not particularly the levels. So, I think what we want to do is promote diets that are associated with risk reduction in patients who are at risk. And, there are many different flavors of that out there. And probably try to prescribe the right diet to patients to modify the risk and not so much the LPA levels.
Right. And so there's a question here about the new medication, inclisiran or Leqvio, saying it also shows an LP(a) reduction. Wondering if this would be similar risk reduction as the other PCSK9 inhibitors. So obviously, Leqvio or inclisiran is a PCSK9 inhibitor that operates by a very different mechanism, and I think we might not know whether or not it's going to show. So we don't have any outcome trials yet with inclisiran.
Exactly. Yeah. We're looking forward to the outcome trials, but they're not. They haven't read out just yet. So you're right that just like with the monoclonal antibodies, inclisiran can lower LPA levels, but we would wait for the outcome trials to understand whether inclisiran lowering LDL and LPA does modify risk.
Another person has a question about the risk of stroke versus heart disease with high LP(a).
Sure. So LP(a) is a risk factor for atherosclerotic disease, and that can manifest as heart disease or ischemic stroke. So LP(a) is tied to ischemic stroke, in particular, not embolic or hemorrhagic stroke. Based on the epidemiology, and especially the genetic studies, it seems like the hazard ratios for LP(a) and heart disease is much higher than that compared to stroke. In interpreting that, one might say that LP(a) is a stronger risk factor for heart disease compared to stroke. And that might be because there are so many other risk factors that can play a very prominent role in stroke, for example, high blood pressure, AFib, for example.
And another person is wondering about the relationship between LP(a) and calcification of the aortic valve. How does that work?
Yeah, that's a great question. So, this is, again, a very likely causal relationship. LP(a) was really the only gene that stood out on the GWAS study looking at genetic determinants of aortic valve calcification. And LP(a), in addition, also predicts progression of aortic valve disease. So in the Astronomer trial, which is a trial that looked at whether statins, rosuvastatin in particular, would be able to prevent the progression of aortic valve stenosis in those with mild to moderate aortic stenosis. And even though that overall trial was negative, the LPA level at baseline, if it's high, predicted faster progression hemodynamically of aortic valve disease, and also predicted the need for aortic valve surgery or aortic valve replacement. So there does seem to be a very tight relationship between LP(a) and calcific aortic valve disease, but also a sort of end manifestation, which is aortic stenosis and severe aortic stenosis.
And then another person wonders, is high LP(a) a strong risk factor for earlier or later in life vascular disease?
Yeah, good question. So, in the population-based studies, it does seem like LP(a) plays a stronger role as a risk factor in those who are younger. And, one way to explain that could be as we age, age is sort of the accumulation of risk factors. And as we age, risk factors acquired later in life that accumulate through time become more prominent. Whereas in the younger population, these genetically determined risk factors, such as Lp(a), which are present at birth, might play a more prominent role. Yes, and those who are younger, Lp(a) does seem to play a more prominent role.
Great. And somebody is wondering if apheresis is being used in the United States. They think that it's only in Europe.
It's commonly used in Europe, particularly in Germany, which does apheresis. Well, you might be qualified for apheresis if you have high Lp(a) over 60 milligram per deciliter and clinically evident disease. But that it's also being done in the US under FDA approval. And again, the indications for apheresis in the US would be an Lp(a) over 60 milligram per deciliter, an LDL cholesterol over 100 milligram per deciliter, and also clinically evident disease, clinically evident coronary disease or peripheral arterial disease.
So another person is asking, is CRP a stable marker? Should people be tested for CRP? If they're tested for Lp(a), should they also be tested for CRP?
Yeah, so there are no guideline recommendations on this yet, but this is what I would do in my practice. And you're right, the CRP is something that in guidelines that describe testing CRP, it's something that should be tested at least twice. It is a very sensitive marker, and any degree of inflammation, even if it's subclinical inflammation, for example, somebody recovering from a cold can cause an elevation in CRP. So if we were to try to understand a person's baseline steady state CRP level, it should really be done outside the context of any acute illnesses and over two separate tests for CRP. So it's a little different than the Lp(a), which again, you probably just need one test to identify those who have high levels.
Okay, let's see. There's some very specific questions of patients themselves. Let's see. If you have a very elevated lipoprotein(a), should you consider aspirin or anticoagulants in the absence of other risk factors?
Yeah, that's a great question. It's made very difficult with a relatively recent aspirin trial showing that in patients who are, this is in the primary prevention setting, so patients without clinically evident disease, regardless of age or diabetes status, it was hard to show a benefit of aspirin, over the potential risk of bleeding associated with aspirin. And the question of whether aspirin can reduce risk in those with Lp(a) without history of clotting disorders or a history of heart disease, it remains open. So we don't have guidance from guidelines, nor from clinical trials to answer that question. One way to think about whether a person should be on aspirin, again, is to calculate their overall risk. And you can do it with the approach we discussed and the approach that we reported in the AHA scientific statement by incorporating Lp(a) levels in their overall 10-year risk. And if you identify someone who's at risk closer to those who have clinically evident disease, then those patients might benefit from aspirin. Another useful tool that might help to find out if a patient might benefit from aspirin or not is to do a coronary calcium score. And regardless of Lp(a) levels, those with a coronary artery calcium score of over 100 seem to benefit from aspirin out of proportion to the risk associated with bleeding with aspirin.
And then one person asks, why is apheresis not being used more frequently? They mentioned that I see the apheresis lowers Lp(a) by 70 to 80%, and they wonder how long do the benefits last?
Yeah, so I think apheresis is certainly an option for patients with high Lp(a). There is a kind of a paucity of availability of apheresis not widely available across the country. So that's one issue. And two, what the data that we have regarding apheresis and risk with Lp(a) is observational. So take that kind of have to think about that in a way when you're trying to incorporate apheresis in your clinical practice. In terms of Lp(a) lowering, it is quite effective at acutely lowering the Lp(a), meaning if you check the Lp(a) level right before the patient starts apheresis, and then again after the patient's done with their 2 hour or so session, the LPA level does go down 70-80%, as does the LDL level. Here in this country, we generally do our apheresis treatments every 2 weeks. So in between treatment sessions, the body, the liver continues to make ApoA and LPA so that the levels do rebound. They don't rebound fully, to pre-treatment levels, meaning that if you have consistent treatment over time, there is a drift towards slightly lower LPA levels. But the other point is that you can model what the time average LPA lowering might be. So acutely apheresis will lower LPA levels by 80%, and there's some rebound over 2 weeks. But the time average lowering over those 2 weeks is something about 30 to 45%. So I hope that's helpful, but I think it certainly has a role in certain patients, again, based on the FDA indications.
And another person asks, I know that you suggested that the guidelines, the Canadian guidelines, the European guidelines suggest one test in an adult level. But this person, one of our attendees, has a very elevated lipoprotein (a) and wonders when his or her children should be screened.
Yeah.
Could they be screened before adulthood?
They could. LPA levels are, we know very well in adults that the levels are quite steady over time. And in children, the levels at birth might be slightly different from the levels in young childhood. And when those levels fully plateau, I think it's another question that remains to be fully defined. For example, there was a poster coming out of the Netherlands a couple of years ago that showed that levels of LPA levels might change even in adolescence. There might be some gradual increase of LPA levels in adolescence, but mild. So it theoretically is still possible, despite the mild elevations that can occur through childhood, to identify whether the child has high LPA or not. We just want that binary answer from one test. Now, so that's kind of a theoretical answer that yes, one might be able to identify whether a child has high levels or not. But I think the more difficult answer is what would you do with that information? We don't really have data to show treating kids with pharmacologic therapies or other therapies, how effective that might be in kids. You might, if you found that a kid had high LPA levels, you might promote very healthy lifestyle habits. So that might be one thing to do. But it is kind of an open question on when or if kids should be screened for LPA.
And so as LP(a), this is a person that said, you said LP(a) doesn't change much, but in the last 3 months, this person's LP(a) increased from 80 to 130, I'm assuming nanomoles per liter. But they do mention that they had Omicron, which could be an acute phase reactant response. What would you say in terms of, should this person wait a period of time and repeat their lipoprotein(a)?
Yeah, good point. And we do know that there are these non-genetic modifiers of LPL levels that I discussed, and one of them is inflammation. So we know that ApoA, the promoter that drives the expression of ApoA, has an IL-6 response element. So when there is acute inflammation, the ApoA levels and therefore the LPA levels can go up. So yes, if one has their LPA level checked during either an acute viral infection or even during an acute hospitalization for a heart attack, for myocardial infarction, those LPA levels may be higher than what typically would be at baseline. So it can make sense to wait 1 or 2 months to check again to get a true baseline level.
And then finally, as we expected, there might be questions like this. Wondering about vitamin C and how that might impact lipoprotein(a). And there's also a question about whether or not zinc, copper, and B vitamins have any influence.
Yeah, so these, again, I'm not quite an expert at the diet and supplements, There are many caveats with these trials that these are typically, hard to do randomized and hard to do controlled. So I'm not sure that there is sufficient evidence to make recommendations on supplements or vitamins and Lp(a) risk here.
Let's see. I'm just looking for, I think we're pretty good. Let's see. Question on how much apheresis costs.
Well, I'm not quite sure, honestly. I do know that apheresis for indicated reasons is covered by insurance. But in terms of what out-of-pocket expenses, I have to admit, I'm not quite expert on that.
Does menopause increase lipoprotein(a)?
Yes, it does. It's another example of how there's hormonal influences on Lp(a). So with menopause, when estrogen levels fall, the Lp(a) levels do tend to come up.
And then I think we're almost out of time, but another question is, if you have a person with a high Lp(a), would it be better to target an LDL goal of less than 70 rather than less than 100?
Yeah, my approach with that would be to first put Lp(a) in context with the patient's overall risk. So if with the additional information of Lp(a), you find that this patient or this person is at high risk, then you would treat accordingly. So you would target that patient's LDL to match their risk. And again, this sometimes is sort of the shared decision-making with the patient. Different patients have different acceptance of what the risks are or what the risk ought to be. And for those who really seek to avoid risk, you might target a lower LDL cholesterol based on the overall risk.
That's great. Thank you so much. And I think that we all got a tremendous amount out of this conversation. And we'd like to thank all of those who donate to the Family Heart Foundation. It's the way we can put these kind of programs on. And so we thank those that do give regularly. Next slide. And we'd like to thank you all for joining us tonight. I believe that this within a few weeks, this presentation will join an archive of webinars on our website where you can go and review it again if you want to hear it for a second time. And thank you so much for your attention tonight.
Thank you, everyone.
Calvin, that was great.